Thanks to the scientific community to give me the chance to be with you today. Our presentation today will be about the thyroid autoantibody between use and abuse and its clinical implications. My first question will be, is it routine to measure the antithyroid antibody for any patient presented by thyroid dysfunction or not? Or only we have some certain indications that can we request this antibody, and this request have clinical implication and can change our decision in the management of the thyroid antibody. So, for example, this lady have the classic or the characteristic features of the mexican. She have molar flush, she have very orbital buttons, some degree of color. So it's clear that patient have primary or hypothyroidism. It is mandatory to request thyroid peroxidase antibody for this lady. It will change our decision of treatment. It can indicate disease activity, or it can even help us in the diagnosis. This is first question. Also, this lady have also what's known as Graves' orbitopathy or Graves' ophthalmopathy, periorbital edema, hemosis of the conjunctiva, and also she have exosomes. It's mandatory to request the TSH receptor antibody to confirm the diagnosis of Graves' disease for this lady or not. The second question will be, when to request the antithyroid antibody? Let's start just this introduction about the thyroid antigen. We already have 3 thyroid antigen. I will clear here in this figure. This is the follicular thyroid cell. This is the basal surface, and this is the colloidal surface of the follicular cell. The first antigen and one of the most important antigen here is the peroxidase. Peroxidase is a key enzyme in the hormonogenesis and synthesis of thyroid hormone. It's responsible for trapping of the iodide inside the cells and the organification of the iodide with the tyrosine on the surface of the thyroglobulin, leading to formation of the mono and diiodotyrosine. So it's very important and the key enzyme in the hormonogenesis of thyroid. The other antigen in the thyroid cells here is the thyroglobulin. Thyroglobulin is a protein synthesis inside the thyroid cells and secreting to the colloid to be stored. When there is activation of the thyroid gland by the TSH, there is endocytosis of the thyroglobulin and proteolysis and release of the free thyroid hormone to be secreted into the blood, and the release of the mono and diiodotyrosine to be recycled in the new synthesis of the thyroid hormone. So we have 3 antigens. The last one, or the last antigen, is the thyroid TSH receptor. TSH receptor present on the basal surface of the follicular thyroid cell, and against this main 3 antigen, we have antibodies that formed against this antigen. So also we have the main 3 antibodies: the thyroid peroxidase antibody, the thyroglobulin antibody, and we have the TSH receptor antibody. Actually, thyroglobulin is detected in the serum of normal cycle, and also it can be increased in any patient with any chronic or thyroid dysfunction. So actually, we can depend on the thyroglobulin or thyroglobulin antibody as a marker for any specific thyroid disease. Actually, this has some importance in some situations, but we can depend or rely on it for the diagnosis of autoimmune thyroid disease. Thyroglobulin antibody also present in the hemothyroiditis as well as the antithyroid peroxidase antibody, but as I said, this is not reliable as a TDO antibody for the thyroid autoimmune disease. 10 to 20% of the healthy individuals have a detectable antithyroglobulin level, and this is logic because already thyroglobulin present inside the thyroid, and antibody can form even in normal population. We have some cases that may be of value for the antithyroglobulin. It is a differentiated thyroid cancer, and we will discuss later in this. also the chronic urticaria and hemoptysis. Let's go to the second antigen and second antibody. This is the TBO or thyroid peroxidase. Nearly all the patients of Hashimoto's thyroiditis have a high serum level of TBO. Actually, this table, we can predict the patients that are at high risk for developing or progression to overt hypothyroidism. So we see here, we have the TSH level, 1, 2, 3, 4, 5, and we have the age of the patient, 20, 30, 40, 50, and so on. And we have the negativity or positivity of the thyroid peroxidase antibody. As we see here, the higher the level of the TSH, from 1 to 5, and the higher the age of the patient, and the positivity of the thyroid peroxidase will markedly increase the possibility of developing overt hypothyroidism for this patient. For example, in this patient, if we have TSH is 4, still within the reference range, and the age of the patient is 50, this patient has a chance for development of overt hypothyroidism within the next 20 years for about 9%, if he is TBO negative. And this chance will increase up to 38% once its TBO become positive. This indicates for us how much this antibody can predict the progression to overt hypothyroidism in even normal population. Let's go to the third antigen and third antibody. This is the TSH receptor antibody. Actually, this is very important test. We have two methods to detect the TSH receptor antibody. TSH receptor antibody can be assessed what is known as binding assay or bioassay. What's the difference between binding and bioassay? Actually, the first assay, which is a binding assay, and this is maybe available on most of the laboratory, it's not costly, and this method cannot differentiate between the TSH receptor antibody, either it's blocking or stimulatory or neutral. So the test will take for me the total TSH receptor antibody in the serum of the patient. So I can discriminate, it is stimulatory, it is blocking, it's neutral. But can I propose from the clinical situation of the patient? So if I have a patient presented for me by cytotoxic symptoms, and I suspect that the patient has hyperthyroidism secondary for Graves' disease, and I request TSH receptor antibody by the binding assay. Then if already I get that the patient have high level, so I suppose that this is stimulatory. It's not blocking and it's neutral. So we can depend on this test. It's more sensitive than the first assay, but it's much less specific for the Graves' disease, because we have the autoimmune hypothyroidism, and in this hypothyroidism we can detect the blocking antibody. So this test by this assay is not specific for Graves because it can be present in the autoimmune, but we can differentiate based on the clinical ground. The second assay, which is not available in all the laboratory, it is based on the bioassay, based on the presence of the transfected cell. So it's a very costly test. And this is known as a TSI, which is a thyroid stimulating immunoglobulin assay. Actually, this test can differentiate between the stimulatory, between the blocking, and between the neutral binding of the TSH receptor antibody. This test is very specific for Graves' disease because he will give me that this is stimulatory immunoglobulin. It's not blocking, it's not neutral antibody. But it's much less sensitive because it may be normal in the mild stage of Graves' disease. Let's back to our first question. Is it routine to measure the antithyroid antibody for the assessment of thyroid function? Actually, it's not necessary. This is the first example. Patient with primary overt hypothyroidism. Almost of these patients have a chronic autoimmune thyroid disease. So the measurement of thyroid peroxidase antibody will add no more value for my diagnosis. And already this patient already permanent, so she already have permanent thyroid failure, and so there is no need, cannot detect the prognosis of the disease because it's actually the patient in need for the replacement therapy all the life. So TBO can add no more benefit for them. So it is not recommended at all to request for this test in this patient. On the other side, we have the patient with subclinical hypothyroidism. This patient, as we see in the last table, that if the TPO is positive, they have a possibility, high possibility, and a great possibility to develop progressive and overt hypothyroidism. So I can start medication even in this patient if they already have TPO positive rather than the patient that have negative TPO test. Also, this is the second example. If I already have patient with cytotoxic symptoms, and already we know that we should establish the diagnosis before starting medication for the cytotoxic patient. We should know either this patient has Graves' disease, multinodular goiter, toxic adenoma, thyroiditis, whatever, before starting medication. And the gold standard here is for the radioactive thyroid uptake, or radioactive iodine, or the thyroid technetium platelet, whatever the methods that we use. But it's the gold standard for differentiated between the cause of thyrotoxicosis is radioactive iodine or thyroid scan. However, if I request T-cell antibody, it's of no value because the gold standard is present and available. On the other hand, if this test or this scan is not available, or it is contraindicated, like the nursing mother or like the pregnant ladies, it is contraindicated to do thyroid scan or the radioactive iodine. So here, the T-cell receptor antibody will be the gold standard, and we can depend on it for the diagnosis of Graves' disease in this situation. The second question, when to request an thyroid antibody? Let's go to this scenario. Pregnant woman, 20 weeks of gestation, TSH is 7. How to manage? Is the measuring of TSH receptor antibody here or the thyroid peroxidase antibody will change our management or not? All of us know that subclinical hypothyroidism has adverse pregnancy outcome on the fetus. It can lead to pregnancy loss, can lead to premature delivery, hypertensive disorder like preeclampsia and eclampsia, and can affect the neurocognitive outcome. So subclinical hypothyroidism during pregnancy have adverse pregnancy outcome. Let's do this table that shows the trimester-specific reference range for the TSH. In non-pregnant ladies, the cutoff value for the thyroid or TSH level from 0.4 up to 4 milliliter per liter. In the first trimester, the TSH, there's some separation for the TSH, maybe you related to the human chorionic gonadotropin. So from 0.1 up to 2.5. And the second trimester from 0.2 up to 3. Third from 0.3 up to 3. So TSH level tend to be more suppressed during pregnancy, especially in the first trimester, which is HCG induced. Let's go to this recommendation. This is the American Thyroid Association recommendation 2017 about the managing of subclinical hypothyroidism during pregnancy. We actually have 3 situations. Either it is recommended for treatment, or the treatment may be considered, or it's not recommended to treat subclinical hypothyroidism in pregnancy. And actually, the TPO here is the cornerstone of the decision. We depend on the TPO for this decision, either to must be treated, may be treated, or not be treated. So, if the TSH level for this patient is more than 10, we don't look to the TPO level. Once TSH is above than 10, we should start medication, and it is recommended to start medication for this lady. If the TSH level is less than 10, but above the trimester-specific reference range, we look for the TPO. If the TPO is positive, so we should manage, and we must manage this patient by levothyroxine and start medication based on the positive TPO and the TSH above the trimester-specific reference range, but less than 10. This is the second situation, which may be considered. We can consider treatment. So this is depend on the physician experience and maybe his opinion about the case. So if the TSH above 2.5, but still below the upper limit of the reference range for the pregnancy, but have the positive antibody. So for example, this for the patients that have TSH 2.8, for example, in the first trimester. So it is above 2.5, but still less than the trimester specific reference range in the second trimester. So this patient, if have positive antibody, we can treat this patient. So we have pregnant women that present by the TSH 2.8 and TPO is positive, and we may consider treatment. even the TSH is normal. And we will discuss the rationale for this. The other situation that the treatment may be considered if the patient have negative TPO and the TSH concentrator greater than the pregnancy-specific outcome but less than 10. If it is negative but greater than the trimester-specific, we can consider the treatment. The last one, it is not recommended if the TPO is negative and TSH is within the trimester-specific reference range. To summarize this algorithm shows us how to manage the subclinical hypothyroidism in the patient with pregnancy. So if the patient is at high risk of thyroid disease, we check for the TSH as pregnancy is confirmed. And we look. If the TSH is more than 10, treat with levothyroxine. Okay, no more workup is needed. Just start medication. If the TSH is less than 0.1, we go to the algorithm of cytotoxicity and manage according to it. And if the TSH is from 0.1 up to 2.5, no further workup, no need for medication. The treatment here is not recommended. Here, this is the debate. If the TSH between 2.5 and 10, we must check for the TPO level. And according to the level of the TSH, we can classify the patient. If the TPO is positive, look for the level of TSH. Between 2.5 up to the upper limit of normal, we can consider the treatment, but it's not mandatory. If the TSH is above the upper limit up to 10, we must treat it by levothyroxine. On the other hand, if the TPO is negative, TSH between 2.5 up to the upper limit of normal, there is no treatment. If the level of TSH between the upper limit and 10, we consider the treatment. So, to summarize, the TPO is increase our possibility for treatments. So once TPO is positive in the subclinical hypothyroidism during pregnancy, we should at least consider treatment or must treatment. If negative, may consider treatment or no treatment. This is the summary for this recommendation. What's the rationale? Why we should treat patient with even with normal thyroid TSH level? Because actually pregnancy is a stressful condition and the ability of the thyroid to augment the hormone production may be compromised, and the patient may develop hypothyroidism during pregnancy. And we know that first effect of the subclinical hypothyroidism during pregnancy, so it's better to start medication at this level. Let's go to the next recommendation from the ATA. It's about the monitoring of the patient. If we have the patient with overt hypothyroidism or the patient with subclinical hypothyroidism, either the patient treated or untreated, or even the patient at high risk of hypothyroidism. So the ATA recommends that the patients should be monitored by the TSH every month until the next gestation, and then once at least at the near of the 30 weeks of gestation. So not only the patient already on the treatment or the patient already hypothyroidism or subclinical hypothyroidism, just the patient have TPO positive or thyroid antibody positive, is recommended monthly to test it or monitored by the TSH for the risk of development during pregnancy. So here the TPO and thyroid antibody can change our strategy and can change our monitoring of our patient. Let's go to the Graves' disease in pregnancy. Yes, if I have patient that presented by cytotoxic symptoms during pregnancy and the patient had no history before of Graves' disease, and I want to discriminate, it is pregnancy-induced thyroiditis, it is thyroiditis or Graves' disease, we can depend only here on the TSH receptor antibody to discriminate between the two entities. So here, radioactive iodine and thyroid isotope scan is not recommended. So here is one of the situations that we must depend on the trap antibody for diagnosis of Graves' disease. And we have sensitivity up to 95 and sensitivity up to 99% for Graves' disease for this test. So this is the recommendation of the ATA in 2017 about that the trap level should be measured when the etiology of hyperthyroidism is uncertain. If we are uncertain about the cause, we should request for the TSH receptor. Because some cases from the clinical practice, we can diagnose that the patient has Graves' disease. For example, if the patient presented by Graves' ophthalmopathy or peritibial myxedema. So the clinical situation for us can take us that the patient have already Graves' disease, so we can depend on the clinical. But if we are uncertain about the diagnosis, we should request the test. During pregnancy, if I want to detect or to evaluate the activity of Graves' disease, assessment of the activity don't depend on the thyroid function if the patient already on anti-thyroid medication. So if the patient already have Graves' disease and she get pregnancy, and I want to assess the activity of the disease. If the patient on medication, thyroid function will not assess the activity for the disease because the patient may be euthyroid while by medication. So I can depend on the thyroid, but I can depend on the TRAP antibody level. So the patient have undetectable level of TSH receptor antibody. So the patient in remission for Graves' disease. If the patient already not receiving medication before and already have Graves' disease, so we can depend on the thyroid function because if the patient is thyrotoxic, so it's mostly have active disease. TSH receptor antibody measurements may be useful to assisted in the evaluation of the disease activity in a woman being treated with antithyroid drug for Graves' disease during pregnancy, as we said before. In many patients, we have already some patient with Graves' disease, and the patient is pregnant and on an antithyroid medication, and the disappearance of the TSH receptor antibody is an indication that the antithyroid therapy may no longer be necessary, and this, in its continuation may put the fetus at risk of hypothyroidism, even if the patient or the mother is euthyroid in the medication. And this is very important because sometimes we have pregnant female on the antithyroid medication. TRAP level assessment here is very important to detect the activity of the disease, because if the TRAP is undetectable, there is option to discontinue the medication. Because here, sometimes there is a remission. We know that the pregnancy may induce remission in the autoimmune disease. So this patient may get the remission, and there is no need for medication at this critical time. So it's better to discontinue the medication and follow up the patient to not put the fetus on the risk of the hypothyroidism. And this is the recommendation of ATA 2017 also. Patients receiving antithyroid drugs for Graves' disease, when becoming pregnant or found to have Graves during pregnancy, should have TRAP level measured at the initial pregnancy visit or at diagnosis using a sensitive assay. And if are elevated, again we can check at the 20 week of gestation. So it's recommended for any pregnant lady on medication for Graves' disease to assess the TRAP level at the initial, once the pregnancy is diagnosed, and later on the 20 week of gestation. And we can take our decision if undetectable level of TSH receptor, there is an option to discontinue medication and follow up of our patient. What about antithyroid antibody in the Graves' disease in non-pregnant women and also in male? Actually, after we finish our course of treatment for the patient with Graves' disease after 12 to 18 months, we should evaluate for the TSH receptor antibody. Why? Because we can classify or can categorize our patient into two groups. Patients that already have persistent elevation of the TSH receptor antibody, and this patient actually have minimal chance to get the remission. And the other patient group are the patient with low or undetectable level of TSH receptor antibody. And these patients actually have a higher probability and high chance to get a remission after discontinuation of antithyroid medication. In the group of elevated TRAP, relapse rate reach up to 20 up to 100%. So it's very high. If you discontinue the medication at that time, up to 100% rate of relapse for this patient. So we should look for definitive treatment, radioactive iodine, or the surgery for this patient. On the other side, the other patient group with low or undetectable level of TSH receptor antibody, they have only chance 20 to 30% risk of relapse. This is the first group, as we said, that if the patient already have persistent elevation, we can continue antithyroid medication for another 1 year or 1.5 years, or option for an alternative therapy like definitive therapy, surgery, or radioactive iodine. In selected patient, we meeting in our clinics that some patients have already on the small doses of anti-thyroid medication for a long time. And this is sometimes this is maybe recommended, but in certain patients, this patient may be young patient with mild stable disease and low dose of numericazole or lismazole. Long-term treatment can be reasonable choice for this patient if the patient doesn't prefer surgery or radioactive agent. And this is the other group that strap is negative, and when the thyroid function is normal at the end of the course, so we can discontinue the treatment at this stage, and the patient have a chance which is from 20 to 30% relapse of his disease. If the patient have a relapse, we can look for another definitive treatment, surgery or radioactive iodine. This is the recommendation of 88/2016 about the measurement of TSH receptor prior to the stopping of anti-thyroid therapy is suggested because it is in the predicting which patient can be weaned from the medication with normal level, indicating greater chance for remission. Thank you.
Thank you, Dr. for this wonderful presentation. Any questions?
أنا عندي فكرة. إحنا نخش الآن.
Thank you for nice lecture, Dr. Am. I want to ask about contraindication with pregnancy.
About
Drugs contraindication with pregnancy.
the thyroid.
Yes.
Yeah. Actually, the medication for the anti-thyroid medication during pregnancy, the first recommended medication is the provisional during the first trimester. The second and third, we can shift it to the numericazole, no problem. Okay, but the first trimester, provisional if available, it's much better and affordable for the pregnancies than the numericazole. Okay. Yeah, if it's not, sometimes it's not available, so we can use numericazole. But if available during the first, provisional Yeah, we can use, yes. If it's not available, yes.
Dr. Wallahi, thank you so much. It's very good lectures. There's a lot of abbreviation عشان كده أنا ما صعب علي أتابع معك but it's fantastic. And I do remember حالة جتني بالICU تقريبا at the end of second trimester, beginning of third trimester. Decreased level of consciousness, shortness of breath. We have done everything is negative except high TSH and very low thyroid hormone. That's my first تقريبا case إنه أنا أشوف severe hypothyroidism in pregnancy case في الICU. This lecture is very well linked مع الكيس اللي أنا شفتها. طبعا كان أول شيء how we gonna treat this patient. IV versus PO or GI access for L-thyroxine. بعد كده I basically introduced myself to this kind of pregnancy and hypothyroidism. That's a very interesting topic for me. How we can like predict, let's say, or make kind of investigation to see if the patient can start or not L-thyroxine before pregnancy. So what do you recommend treating severe hypothyroidism coming to the ICU? Thank you.
Thank you, Dr. for your question, very nice question. Actually, the interpretation of the thyroid function in the ICU patient is very difficult because we know that we have the non-thyroid illness or sick thyroid. So, especially in the ICU, patient is critical, and sometimes there is a disarrangement of the thyroid function for the TSH, and we have multiple situations, multiple parameters for the TSH and TSH4. Except if the patient have classic pictures that already have hypothyroidism, and hypothyroidism is responsible for his presentation. For example, if I have patients in the ICU that presented by hypothermia, by patient presented by hypoventilation. So the very high TSH level and very low T3 and T4 in this patient mostly related to hypothyroidism. But because we're facing in the ICU, many patients have only non-thyroid illness. This arrangement, TSH is high or low, T3 and T4 may be suppressed or elevated, and this is a part of the cytokine release in the patient with ICU. So we can here depend only on the clinical assessment for the patient to decide if this patient already have hypothyroidism, and hypothyroidism is responsible for his ICU presentation, whatever the presentation. Once the patient is diagnosed that he already have hypothyroidism, and we should start medication. We know that the IV thyroxine is not available here. So here the treatment mainly is supportive treatment for the patient, to guard against hyperventilation, to guard against infection, to guard against the shock for the patient. So mainly a supportive treatment, and we can start even while rectal tube. We can give the thyroxine to better absorption of the euthyrox during through the rectal route, and we start the medication. So it's not mandatory to start IV if it's not available. We can depend on the on oral or rectal route, and the main medication or main treatment is for supportive treatment.
وما أعرف في ستاندر عندنا الآن في البريجنسي we do those kind of like investigation. دكتورة جميلة بتساعدنا في investigation بنعملها like الانتيبوديز والتيس والأشياء اللي بنعملها في البريجنسي.
طبعا if the patient already have subclinical hypothyroidism, we should request for the TBO because it will guide our choice of treatment if it's recommended for treatment or not. So the TSH receptor the TBO thyroid peroxidase antibody is recommended for any patient with subclinical hypothyroidism during pregnancy. Also, the patient with cytotoxic symptoms during pregnancy, we can differentiate between thyroiditis and the Graves' disease using TSH receptor antibody, because we know that the thyroid radioactive iodine and the thyroids can use the technician technique is contraindicated during pregnancy. So we can't depend on this study for the evaluation, but we can depend on the antibody. Refusal of insurance. No, but it is mandatory for the patient. Otherwise, how can I manage the patient? Some patients are pregnancy induced, hyperemesis, gravidae, like that. Again, the picture, the same picture of hyperthyroidism and Graves' disease.
Thank you, Dr. Amr, for this lecture. Thank you for our list of attendance. And see you soon in the next meeting.
والله أنا جدا مستاء إنه ما في عدد كافي من الأخبار في